Thank you for the invitation. I have to warn you, I'm a surgeon, I'm not a radiologist, so now you know. I'm from Copenhagen. This is my hospital. No. This is my conflict of interest. This is a better image. This is the largest hospital in Denmark, in Copenhagen it's placed. So this is the Department of Vascular Surgery. It's a very big department, maybe one of the largest in Europe, with 32 dedicated vascular beds. We have 4 to 5 operating rooms daily, doing all kinds of procedures. We do all the open, the hybrid, the angio. We do all the endovascular stuff ourselves. All in all, it's 2,600 arterial operations per year. We have a very large outpatients clinic, and that's more or less why I'm here. We do all the ultrasound ourselves as a vascular surgeons and vascular nurse sonographers. There are more than 20 special trained nurses. You can see some of them here. They always look happy. We have 10 rooms in the outpatient clinic running in parallel every day with ultrasound systems. We do an enormous amount of vascular ultrasound examinations, 15,000-ish per year, only vascular. So I don't know anything about ultrasound of structures that are not carrying blood. I would like to we have for many years done a lot of research on how to optimize ultrasound of abdominal aortic aneurysms. This is the classic approach with it could be a C5 curved array transducer. There's one here. And then you get this image. You remember to use I think there's a pointer here, to put it on aortic preset, otherwise you get confused. And you make a transverse AP diameter from here to here. That's it. But can you imagine some pitfalls in this strategy? If you're going to measure a diameter, I will help you with that. So this looks simple. You're just measuring it from the AP diameter from the anterior wall to the posterior wall. But can you be sure that you don't have this angle issue? I think this is one of the most common mistakes in the novice operators is to not control the angulation. If you have a very experienced sonographer, they do this. They combine the transverse and the longitudinal image to a kind of 3D reconstruction in their head. So it's difficult to improve the performance of a sonographer with 20 years of experience, but for the novices, this is for sure a problem. Another issue is what I call rotation mistakes. This looks nice. I guess you agree. And then you can see this is baseline from one of our studies, and then after 6 months later, the aneurysm was growing, apparently. But it was not. It was because the sonographer has slided to one side of the abdomen of the patient. So you can see, where should you put your measurements? This is what's the right way to do it. There's several ways to make mistakes here. One of our tips and tricks is to focus on the vertebra and the vein, because then you would have seen that the vertebra is here and it's different from here. And then, but it's not easy, and you need to be able to reassess the old images to catch this. Another common mistake is where to put the calibers. Should it be outer to outer? Should it be inner to inner? Adventitia to adventitia? I think the most important thing is to find a method that is reproducible and then agree that you do the same each time in your institution. But I would warn about this British tradition, inner to inner, because then if the calcified thrombus in the aneurysm is growing, then the aneurysm is getting smaller. It doesn't make sense. I think in the guidelines, the new guidelines for vascular surgeons, they suggest the outer to outer. I don't agree. We rely on the inner to inner. But then you need to look at the images and you need to decide where to put the calipers. I think in this image, this is a good image. It's probably quite easy. But what about here? Which one of these structures are the aneurysm wall? So, because of these possible mistakes, you will face this. This is a 15 years old study from the British Journal of Surgery, where they looked at several studies that have reported reproducibility of 2D ultrasound in abdominal aortic aneurysms. And I think the most scary stuff is this, that in approximately half of the studies, they have a variability of 5 to 10 millimeters. As a vascular surgeon, that is, that means if we should operate him or if we should let him wait another year before we do the CT scan. Also, you probably know this, that conventional ultrasound underestimate the true diameter of the aneurysm, probably by 5 millimeters. Of course, if you know that, and you have a very strict protocol, and you do this the same way every time, then you can just, add these 5 millimeters to, or subtract them from your measurements, and then you will get the CT measures. But this is well known. This is the same aneurysm measured with ultrasound and with CT, and you can see these lines should overlay each other, and they don't, and there's approximately half a centimeter between. So this is half a centimeter, and before you could miss 1 centimeter, now it's suddenly 1.5 centimeter if you are unlucky. Sometimes these mistakes, are good for each other because it reduces each other, but if they lay on top of each other, it can be a lot. And we know that 5 to 10% of all aneurysm ruptures are on aneurysms that we actually believe are not very big. They are sub-threshold ruptures. I think this is because we do wrong measurements. It's not because small aneurysms suddenly starts to rupture. It's because they have been understood, or the diameter was wrong from the beginning. And so I would like to try to persuade you that you should consider using a 3D reconstruction of the aneurysm instead, because then most of these potential mistakes will be solved. To do this, you need a matrix transducer. The matrix transducer can do 2 things, probably more, but I use it for 2 things. You can make an image like this, real-time cross-sectional and longitudinal imaging, and you can have this volume sampling where you get an electronic sweep of the aneurysm. This is an example of how we do it today. All aneurysms in Copenhagen are measured with this dual plane mode. So you remember this, we have this potential angulation issue. You can solve it with this, because here I'm I can secure that this is going to be a slide of a part of the aneurysm that is perpendicular to the center line. So I see 2 dimensions live in the same image. We have shown that this is much more. It reduces the interoperator and intermodality variability with 50% if you do this. But you can do it even better if you take advantage of this 3D reconstruction of an aneurysm, where you, with this electronic sweep, are able to do 3 imaging planes of the aneurysm, like this, A, B, C plane. This is the 2 you saw before, and this is this reconstructed C image. Then we take that acquisition into, at that time, a prototype software, and you can see that it can more or less fully automatic reconstruct the volume of the aneurysm, and it can put in a center line, and you can decide what you want to do perpendicular to that center line. It could be the largest diameter in any direction, or the largest diameter in the AP plane or lateral plane, or whatever you decide. And now we have a mean difference compared to 3D CT angiograms of less than 2 millimeters. And this is, this 3D CT, that's a reconstructed CT. It's not the usual CT that you normally look at where you just scroll over the screen. So this is a modality that is much better than what most consider is the standard. I showed you before the prototype software. Now it has, on these systems, it is fully automatic 3D ultrasound software. We call it the AAA model. And you'll get it in a few seconds when you push the buttons. We're going to play with that on the systems. We're also going to try to scan some models. So based on this looks nice. We discussed, would this technique be able to make novices to experts if it is as good as I say? You can see it just spit out the diameters here. So we have 2 groups of ultrasound operators. This team of very experienced vascular sonographers, they do 200 to 300 abdominal ultrasound examinations per year, only looking for abdominal aortic aneurysms. And then there was this group of happy medical students with no ultrasound experience. I promised them pizza, and if they would come and be part of the study, and then medical students, they just come if they can eat something. So I gave them a 45-minute theory of how to use what is ultrasound, what is an ultrasound system, what does the buttons mean. And then I had 1 patient they were allowed to train on with me 45 minutes. That's it. And they have if they admitted that they have used ultrasound before, we excluded the medical students. So we recruited 9 patients. They were very patients because they were scanned. Each patient was scanned by 13 experts and 16 novices. And all operators were asked to do a 2D ultrasound and a 3D ultrasound. And we looked of limits of agreement as the best expression of variance, and that is connected to the standard deviation. So of course, the novices performed inferior to the experts. You can see there's a level of agreement of nearly 14, and here it is nearly 8. Significant change. Significant difference using 2D ultrasound. Then we allowed them to use the new tool, and suddenly you can see what happens with the novices, the blue arrow here. They improve from 14 to 9.5. And suddenly we were unable to discriminate novices from experts. And we literally took all their scans. We didn't sort them. Some of the scans was incredibly bad. You know, they have tried to image a bowel or the vertebra or something strange. But the system was able to correct it. And they were not allowed to, they did this, and then they did this, but they were not allowed to see the reconstruction because we would avoid that they were guided by this. So, I'll stop talking in a moment. The conclusion, giving novices this 3D tool would significantly improve their performance. And from this to this. And what does that mean in clinical reality? This means that if you have a 5 centimeter abdominal aortic aneurysm, it would, if you let them use the 2D ultrasound, they will have a variance of plus minus 7 millimeter. And if they use the new tool, it was plus minus 5 millimeter. That's a 30% improvement. Very few intervention can improve anything with 30%. Try to look at some of the big landmark studies of new medical drugs. You know, it's 4% fewer are having a thrombose in the leg if you give them a new anticoagulant. And remember the figures we had in the beginning, that we were talking about that the best studies in this British Journal of Surgery had an inter-observer reproducibility of approximately 5 millimeter. So we turned these novices into experts according to this. And, you know, these 5 millimeters, I think it sounds a lot. But remember, these were really rookies. They have no clue about ultrasound. So if you have someone that has, you know, some ultrasound experience, you must expect that these 5 millimeters would be even less. Time for hands-on. We only have healthy models, luckily, I hope. But we have the AAA app on all 3 systems, and we have acquisitions from Copenhagen also in the system, so you can scan a model and then you can try the new app on the acquisitions from Copenhagen. This is me running around at the helipad on top of the hospital. You should not do that when the helicopter arrives. If you don't know where Copenhagen is, it's here. This is the view from my office. This is a power plant, and it has been turned into a ski slope, so you can do summer skiing here. So you're welcome, Copenhagen, if you want to see this beautiful city. Any questions, please? Yes?
Yeah, have you tried the system, the method on the complicated patients, meaning like overweight, and because I imagine it affects the visibility of the 3D scan.
Actually, the experienced sonographers and physicians who do the complex patients, they use it today as the AAA model as a kind of mentor. So if they're a little bit in doubt, is this right? It is difficult, and then they push the button, and get this, you can say, electronic assistant or whatever. And if the two, if they agree, then it's probably right. You know, and for my sake, it's a good thing, because otherwise I have to come. So it's for surely it works on the tricky cases as well, and it has this standardized way to place the calipers, so you don't need to use a lot of time to do that. It's as far as I understand it, they calculate the difference between the pixels, so it's not a discussion if it should be here or there. It should be there. I think you should spread around the systems, and then we can. Another discussion that we've had in Copenhagen is: should you measure in diastole or systole or what? You need to agree on that in the institution.
Yeah, and just to be.
And do it the same time every time.
Yeah.
We always measure in systole.
Okay. So you take a clip and then you go and you find the.
And it's very easy. Just push the. You don't need to.
I don't need to.
No. Just freeze, and you have 300 frames.
So yeah, I go there.
So we simply do that.
And you do it systole where it's divided.
And one of my favorite questions is, if you measure the diameter on a CT scan, is it a systole or diastole? You know, nobody can tell me. No.
It varies.
Exactly. So it's so that's why you should use ultrasound, because here you can control it.
But yeah.
It's going to be a mix of systole and diastole, probably on a CT scanner.
Yeah.
Yes. Now we can. Good. Try this. And you push this one, and it's important that you there are several possibilities. It's important to take abdominal vascular.
Yeah.
I warn you, this application has been made and tested and validated on patients with aneurysm. So it's and this is the smart stuff.
So now I get 2 planes.
So now you need to tilt, so you get this perpendicular.
Yeah. And you can play it.
I'm not satisfied. This is not perpendicular.
You want to see the vessel?
It has to be like this.
Okay. Okay.
Exactly.
Like this. Okay.
So now you're sure that you make a perpendicular slice of the sausage here.
Yeah.
Understand?
Yeah. So again, I choose. Okay, that's even easier to find.
Yes. And systole, you can see actually on a healthy aorta, it actually means a lot. Systole and diastole.
Yeah, it does affect it. Definitely. If
Good.
you want to do 3D, like you can do.
So now you have this on, and then actually in the Copenhagen business, we then measure the diameters here and here. Save. Okay. Now you have to unfreeze, find a good image, make it perpendicular. We ask the patient to do a breath hold.
Can you hold your breath, please?
Let's see. Hold your breath. Hold it. Hold it. Hold it. Hold it. Thank you. So now we can release pressure. Now you have this ABC planes.
Mm-hmm. Yeah.
And you can push the AAA.
Okay.
So now it's trying to figure out if this is an aneurysm or not. I guess it gets not bad. So it's actually possible to do edits. Now
it's native or
exactly.
So it's native.
Yes. It's a little. So it suggests this one.
I guess you can.
Let's just say it's good. There's actually possibilities to edit this.
Yeah.
So if you accept, you just say accept.
Yeah. Okay.
And then you get the diameters here.
Oh. Okay. Nice.
Like before we had like 14 and now we have like 18.7.
Okay, I didn't pay attention.
Maybe.
But as I mentioned, this has not been validated on patients with aneurysm.
Yeah. Okay.
The system believes that there must be an aneurysm, so it gets confused. There's
Okay.
a kind of random forest plot running,
To see
kind of machine learning.
of non-aneurysm, it was not tested on non-aneurysm.
No, it's not designed for non-aneurysm
yeah,
patients,
okay.
so it's especially designed for patients with aneurysm. And that's very important because you follow them up, you have repetitive scans, and at a certain point, you send them to a CT and surgery.
Okay.
So that's why you need to push that button,
Yeah.
surgery on the right spot.
Yeah. Okay.
Next one.
But as a surgeon, you don't rely only on ultrasound because you want to see like the distance from the.
No. We don't plan surgery on this.
Yeah. Okay. So
No,
it's just
we
for
select them
follow-ups.
for surgeries, and if they approach the surgical threshold, I think it's zoomed. I have to remove this. Like this. Now it's raw. And here you have the aneurysm.
Yeah.
Good.
Okay, so if I freeze.
Yes. And now you try to use the trackball, and you need to take the
The systole.
systole.
Okay.
Yes, that could be this one. And you do the measurement. Or we test your theory. No, you have to.
To take at this border.
No, AP.
Yeah. Okay. Yeah.
It's because ultrasound of the lateral borders are very poor.
Okay.
Because the ultrasound beam goes
Like this.
parallel to this. There's no good
Okay,
echo.
so I have,
1.4.
Yeah. The same.
Okay,
measure,
let's check it with the 3D. And then you select this one and make sure that it starts in abdominal vascular.
Okay.
If you don't start in abdominal vascular, you will not find the AAA app.
Yeah. Yeah. Because
Okay.
we can only reconstruct.
Yes.
Yeah.
Is it also lateral approach, or just if someone has like, is overweight and has lots of air bowel?
Yes, you can do that.
You do it in your facility?
Yes, sometimes we do. It's not that often it's needed.
Usually you see it.
Yes, I think we see it. Yes. And maybe you should just, for fun, try to use this X-plane, so you can try this strange sensation that you have two. You need to master two planes.
And if I
In
do
the beginning,
this,
then
I can change the. Okay. Just.
it doesn't matter.
It doesn't matter if
No.
I do like this. Okay. Okay. I thought if I. Okay.
And you can adjust it as any image you like to.
Okay.
Yes, that's not bad.
Okay. And so I take now this is.
You can do the measurements here again.
Yeah.
See if you agree. Yes.
Okay.
Close.
And now if I want to make a reconstruction now,
Then
3D.
you need a live image, and you can see this button here called Start 3D.
Okay.
Okay.
And I have to focus on something. Or?
No, you just need to have a steady hand, and you need to have the vessel in the middle of the image.
Okay, like this.
Yes,
Okay.
and then breath hold. Hold your breath. Push. Thank you.
Okay.
And then you can put it back on the
And after.
rack, and then you push the AAA, and you have to decide if you want it to be in a moment, if it's a virgin vessel or a post EVA.
Okay.
Here you need to decide. You can just push down here.
Okay, so there I put native.
So this is native.
Okay.
So now it's thinking, and then you can. I think it looks a little bit strange here,
Yeah.
to be honest.
Yeah,
And you
yeah.
can see this is for surely not right.
No, for sure. Okay. But if we want this
but-
measure,
Then you just push accept, and then it gives you your
yeah,
measures.
yeah.
It's not right.
no, it's not right.
So
Okay.
next one, you can try to work on. We have some of the.
The data sets?
Yes, I cannot find it.
Yeah, I'll show you where.
There's an
Yeah,
EVA. Maybe
this
it's
is-
below.
Yeah, you're looking for the native,
native?
one? Yeah.
Ah, here it is. Who? You have to you have to do a reconstruction of a real patient.
Okay. So yeah.
Just push the. I don't think it matters.
So go AAA. So that's a patient with an aneurysm?
That's. I think that's one of the Copenhagen patients, and that you can try to. I would be a little bit not satisfied with this, so I think you should push edit.
Oh yeah. Okay. So now.
And we had it. It was in.
Click edit to
Actually,
border.
we should have. I think go out, and then you should. It's a native. Maybe this would help.
Yeah.
Yes.
It's a little bit better, but let's say I want to
Yes.
edit the
You want to.
width.
I think you just make dots.
Oh. Maybe on the
You
right. So
You just you use this button. So you do, for instance, if you. I think it should be here. You could say.
Oh.
You see?
Beautiful. Yeah. Okay. So yeah, I messed it up because of.
And I think it's possible to there's a clear all button if you goes berserk, and then you can start over.
Yeah. Is there a significance to the, like, let's say you have an intramural thrombus, okay?
It should be able to see it actually. It looks at the pixels.
But as a surgeon, you wanna know this data. I mean, you wanna know how much lumen is open and how much there's, or you wanna know just like the total diameter
Yes.
for a follow.
If for pragmatic point of view, it's only the maximum diameter because that is correlated to rupture risk. I know that we are in the moment discussing if the thrombus thickness might be an additional risk factor,
Yeah.
but it's not part of any guidelines.
I
So
thought
it's
it will be already tested at some point.
No.
Because,
we never do. We are not interested in the thrombus.
okay.
You can always get your EVA device up, and you can for sure always operate them open, thrombus or not.
Yeah.
The,
Either goes through the thrombus.
yes, you just push it through.
Okay.
So now you push. Let's see. Let's
I
accept.
guess.
Yes.
Okay.
So now it gives you the largest AP diameter and the lateral diameter and the largest diameter in any direction. It actually also gives you a partial volume here.
Yeah. Nice.
Yes.
Okay. Yeah. I have a paramedical question.
Okay.
Like meaning, do you do a short fellowship at your institution if I want to come and study for a week or two, just to see lots of cases and to bring knowledge to
Yes, we do.
my department?
We are discussing it in the moment to make short fellowships. Do you have access to equipment like this at home?
Yeah, we have the Epic 7.
Ah, perfect.
So we have. I think we also have the transducer to see. But I think it will be very valuable for
Sure.
us because we do it as we understand. But for instance, nobody told me, okay, just take the systolic. Okay, that's just like a short thing that I didn't know, and it matters, right?